What do you consider to be the most important qualities for an ICU nurse?
As an ICU nurse, I believe the most important qualities are a combination of clinical expertise, emotional resilience, and strong communication skills. First and foremost, clinical competence is crucial, as ICU nurses are responsible for managing patients with life-threatening conditions. This requires a deep understanding of critical care protocols, the ability to quickly assess a patient's condition, and the skill to intervene decisively when necessary. The ICU is an environment where every second matters, so being able to make informed decisions under pressure is essential. Emotional resilience is another key quality. Working in the ICU often means dealing with high-stress situations, sometimes involving patients in critical or end-of-life care. It's vital to remain calm, focused, and empathetic, even in the face of difficult outcomes. Resilience helps in maintaining professional integrity while offering emotional support to both patients and their families, who may be going through some of the most challenging moments of their lives. Lastly, communication is integral to effective ICU nursing. ICU nurses are part of a multidisciplinary team, and clear, concise communication is necessary to ensure seamless collaboration with doctors, respiratory therapists, and other healthcare professionals. Additionally, being able to explain complex medical information in a compassionate and understandable way to patients' families is critical in building trust and providing holistic care. These qualities together enable an ICU nurse to provide not only high-quality clinical care but also compassionate, patient-centered support.
How do you prioritize tasks and manage your workload in a fast-paced ICU environment?
In a fast-paced ICU environment, effective prioritization and workload management are essential. I rely on a combination of clinical judgment, time management skills, and adaptability to handle the often unpredictable nature of critical care. The first step in prioritizing tasks is always assessing the acuity of the patients. I focus on those in immediate or potential life-threatening situations, ensuring their stability before attending to less urgent needs. For example, managing airway, breathing, and circulation always takes precedence, followed by tasks such as medication administration, monitoring vital signs, and patient comfort measures. Once I've addressed the most critical issues, I move on to tasks that are time-sensitive, such as delivering scheduled medications or treatments. I make use of checklists and electronic health records to stay organized, ensuring that I don't miss any essential duties throughout the shift. In an environment like the ICU, multitasking is often required, but I always aim to stay focused on one patient at a time when delivering care, as mistakes can happen when attention is divided. Teamwork is also a big part of managing the workload. ICU nursing involves collaborating with other nurses and healthcare professionals to ensure patients receive the best care. I'm always open to assisting colleagues when I can, and likewise, I'm not hesitant to seek help when a situation demands more hands on deck. Finally, maintaining flexibility is crucial. The ICU is unpredictable, and I regularly reassess my priorities throughout the shift, adjusting my focus based on patient needs and emerging situations. This dynamic approach allows me to provide high-quality care while managing the demands of a fast-paced environment effectively.
Can you describe a challenging situation you faced in the ICU and how you handled it?
One of the most challenging situations I faced in the ICU involved a critically ill patient who was rapidly deteriorating due to multi-organ failure. The patient was on a ventilator, requiring continuous hemodynamic monitoring, and their condition had taken a sudden turn for the worse. This situation was particularly stressful, as the patient's family was anxiously waiting for updates, and multiple interventions needed to happen simultaneously. In this scenario, my first priority was stabilizing the patient. I immediately contacted the ICU team, including the attending physician and respiratory therapist, to initiate advanced interventions. While awaiting the team's arrival, I focused on maintaining the patient's airway and monitoring vital signs, adjusting medications and ventilator settings as needed. Remaining calm and composed was critical, as I had to make quick, informed decisions in a rapidly changing environment. I also made sure to communicate clearly with the team, providing real-time updates on the patient's status to ensure everyone was aligned. At the same time, I had to balance the clinical demands with supporting the family, who were understandably distressed. Once the immediate crisis was under control, I took a moment to update them with compassion and clarity, helping them understand the gravity of the situation while providing reassurance that we were doing everything possible for their loved one. This experience taught me the importance of staying calm under pressure, working collaboratively with the multidisciplinary team, and maintaining clear, compassionate communication with the patient's family. It reinforced my ability to think critically and manage highly stressful situations in the ICU, ensuring both clinical excellence and emotional support during a difficult time.
How do you balance the emotional demands of ICU nursing with maintaining your own well-being?
Balancing the emotional demands of ICU nursing with maintaining my own well-being is essential for both my effectiveness as a nurse and my long-term career sustainability. The ICU can be emotionally intense, as it often involves caring for critically ill patients, some of whom may not survive, and supporting families through incredibly difficult times. To manage this, I focus on building emotional resilience and practicing self-care, both in and outside of work. In the ICU, I make it a point to stay grounded in my role, focusing on providing the best possible care while acknowledging that some outcomes are beyond my control. I rely on the support of my colleagues, as sharing experiences and debriefing after challenging cases with a team that understands the stresses of critical care can be incredibly helpful. Additionally, I make time to check in with myself throughout the shift, taking short breaks when possible to reset and reflect. This allows me to process my emotions in manageable increments rather than letting them build up. Outside of work, I prioritize activities that help me recharge mentally and physically. Exercise, whether it's yoga, running, or a simple walk, is an important way for me to relieve stress and maintain a healthy work-life balance. Spending time with family and friends also provides a strong emotional support system and helps me maintain perspective. Additionally, I practice mindfulness and meditation, which help me process difficult emotions and prevent burnout. I believe that maintaining boundaries between work and personal life is crucial. While I give my all to my patients during my shifts, I've learned to compartmentalize and leave work behind once I'm off duty, allowing myself to fully disconnect and recharge. This balance between emotional engagement at work and intentional self-care ensures that I can continue to provide compassionate care while protecting my own mental and emotional well-being.
What is your understanding of the role of teamwork in ICU care?
Teamwork plays a critical role in ICU care, as patient outcomes in this high-stakes environment depend on the seamless collaboration of a multidisciplinary team. The ICU is a place where no single healthcare professional can manage all aspects of care alone. Each team member brings a unique skill set, and working together effectively ensures comprehensive, patient-centered care. As an ICU nurse, I see myself as a crucial part of this team, alongside doctors, respiratory therapists, pharmacists, physical therapists, and other specialists. In my experience, clear and constant communication is the foundation of strong teamwork in the ICU. For example, during shift handovers or when a patient's condition changes suddenly, accurate and concise communication helps ensure that all team members are up to date and can respond appropriately. When everyone is aligned in terms of patient care goals and aware of their roles, the team can act quickly and efficiently, which is essential in critical care settings. Collaboration is also key when developing care plans. Nurses often spend the most time with patients, monitoring subtle changes in their conditions. We provide vital feedback to physicians, contributing to decisions about treatments and interventions. This continuous exchange of information helps ensure that every aspect of the patient's needs, whether medical, physical, or emotional, is addressed. Equally important is the ability to support one another, especially during high-pressure situations. In the ICU, emergencies are frequent, and being able to rely on your team to step in, assist, or provide guidance makes a significant difference. Teamwork fosters an environment where patient safety is prioritized, and care is delivered more efficiently. Ultimately, the collaborative efforts of a well-functioning ICU team lead to better patient outcomes, faster recovery, and a more positive environment for both patients and healthcare providers.
Describe a time when you had to make a difficult ethical decision in the ICU.
One situation that stands out involved a patient who was in critical condition with multiple organ failure and had very little chance of recovery. The medical team had exhausted all treatment options, and the patient's prognosis was poor. The family, however, was struggling with the decision to withdraw life support. They were hopeful for a miracle, but the patient's condition was irreversible. As the ICU nurse, I found myself in a difficult position, balancing my responsibility to provide compassionate care while also respecting the family's wishes and the patient's dignity. The ethical dilemma was clear. Continuing life-sustaining treatment that offered no real benefit to the patient was against the principles of non-maleficence, which is the obligation to do no harm. Yet, at the same time, respecting the family's emotional needs and their hope for the patient's recovery was essential. I had to navigate the fine line between advocating for the patient's best interests and being sensitive to the family's beliefs and desires. To handle this, I facilitated a meeting between the family and the medical team, including the attending physician and social worker, to discuss the patient's condition and prognosis openly. I made sure the family fully understood the medical situation, while also expressing empathy for their emotional pain. My role was to provide support, help the family process the information, and ensure they felt heard, without imposing any decision on them. Ultimately, the family decided to transition the patient to comfort care after a series of conversations. It was a difficult decision for them, but I believe my role in providing compassionate communication and supporting their emotional journey helped them come to a decision that aligned with both the patient's best interests and their values. This experience taught me the importance of empathy, clear communication, and ethical sensitivity when facing difficult decisions in the ICU.
Describe your actions during a code blue situation in the ICU.
During a code blue situation in the ICU, my primary actions are focused on responding quickly, staying calm, and working cohesively with the team to ensure the best possible outcome for the patient. When a code blue is called, indicating that a patient is experiencing cardiac or respiratory arrest, my first step is to immediately assess the patient's condition and initiate life-saving measures. If I am the first on the scene, I check the patient's airway, breathing, and circulation, while simultaneously calling for help. If necessary, I begin chest compressions to maintain circulation, following the Advanced Cardiovascular Life Support (ACLS) protocol. It's essential to remain focused and efficient in these first moments, as time is critical in cardiac arrest situations. Once the code team arrives, the situation becomes a coordinated effort, where clear communication is key. As an ICU nurse, my role could vary depending on the team's needs, but I am often responsible for managing the airway by assisting with ventilation or administering oxygen, setting up and operating the defibrillator, or providing medications as ordered by the team leader. I ensure that all interventions are carried out precisely and promptly, such as administering epinephrine or other drugs, drawing up fluids, or monitoring the patient's heart rhythm. Throughout the code, I also help keep track of the timing of interventions, such as how long compressions have been performed or when medications were administered. Documentation is crucial, so I either record these events or work closely with another nurse who does, ensuring all actions are accurately logged for the team to review later. In a code blue, teamwork is critical, and it's essential to remain composed under pressure. I trust in the training of my colleagues and communicate clearly to ensure that the entire team is coordinated. After the patient has been stabilized or a decision has been made to stop resuscitation efforts, I often participate in the debriefing, reflecting on what went well and where improvements can be made, which is crucial for continual growth in handling these high-stakes emergencies.
What measures would you take to prevent VAP in a ventilated patient?
To prevent ventilator-associated pneumonia, VAP, in a ventilated patient, I would follow evidence-based practices and protocols designed to minimize the risk of infection. These measures focus on maintaining proper hygiene, optimizing patient positioning, and ensuring effective ventilation practices. One of the most important steps is ensuring strict adherence to infection control protocols, such as hand hygiene and using personal protective equipment, PPE, appropriately before and after touching the patient or the ventilator. This prevents the transfer of pathogens that could lead to pneumonia. In addition, regular oral care with an antiseptic solution, such as chlorhexidine, is essential for reducing the bacterial load in the patient's mouth, which is a common source of infection in ventilated patients. Another critical measure is maintaining the patient in an appropriate position. I would elevate the head of the bed to between 30 and 45 degrees, which helps reduce the risk of aspiration, a key factor in the development of VAP. This positioning minimizes the possibility of gastric contents or secretions entering the lungs. Suctioning the patient's oral and subglottic secretions is another important preventive step. Regular removal of secretions, especially from above the cuff of the endotracheal tube, prevents them from being aspirated into the lungs. However, it's important to avoid overly aggressive suctioning to reduce the risk of trauma to the airway. I would also ensure that ventilator settings are appropriately adjusted to avoid unnecessary prolonged mechanical ventilation. For instance, promoting early weaning from the ventilator, when the patient is stable enough, reduces the duration of exposure and, therefore, the risk of developing VAP. Implementing a daily sedation vacation or spontaneous breathing trials can help identify when the patient is ready to start the weaning process. In summary, a combination of meticulous infection control, regular oral hygiene, proper patient positioning, careful secretion management, and timely weaning from the ventilator are the most effective measures I would take to prevent VAP in a ventilated patient.
How would you assess a patient with a suspected stroke in the ICU?
Assessing a patient with a suspected stroke in the ICU requires a prompt, systematic approach to identify the type and severity of the stroke, allowing for rapid intervention. The first step is conducting a focused neurological assessment, starting with a review of the patient's presenting symptoms, medical history, and timing of symptom onset. In stroke management, the time of onset is critical, particularly in determining eligibility for treatments like thrombolytics in ischemic strokes. One of the most widely used tools in stroke assessment is the NIH Stroke Scale, NIHSS, which evaluates the patient's neurological function in several key areas, including consciousness, motor strength, speech, and sensory function. I would perform a detailed assessment of the patient's level of consciousness, asking simple questions to gauge orientation and following commands to test cognitive function. This provides an early indication of the severity and location of the stroke. Next, I would evaluate the patient's motor function by asking them to raise their arms and legs, checking for any weakness, paralysis, or asymmetry. I would also assess facial symmetry by asking the patient to smile or raise their eyebrows, looking for drooping or weakness on one side of the face, which could indicate cranial nerve involvement. Testing for limb ataxia or coordination difficulties helps determine if there is any impairment in movement control. Speech assessment is another important aspect. I would ask the patient to speak or repeat a sentence to assess for slurred speech, dysarthria, or difficulty finding words, aphasia, which are common signs of a stroke affecting language areas of the brain. I would also evaluate their ability to understand and follow instructions, indicating potential deficits in comprehension. Simultaneously, I would monitor vital signs, especially blood pressure, heart rate, and oxygen saturation, as these can affect brain perfusion and are crucial in managing a stroke. For example, elevated blood pressure might be present in an ischemic stroke as the body attempts to compensate for reduced cerebral blood flow. Continuous monitoring of these parameters is essential for guiding treatment decisions. In addition to the bedside assessment, I would ensure that the patient receives immediate diagnostic imaging, such as a CT scan or MRI, to confirm the type of stroke, ischemic or hemorrhagic, and guide further interventions. If the patient exhibits signs of a hemorrhagic stroke, swift action may be needed to manage increased intracranial pressure or stop bleeding. If an ischemic stroke is suspected, I would collaborate with the ICU team to determine the patient's eligibility for thrombolytic therapy or mechanical thrombectomy, ensuring the intervention happens within the appropriate time window. In summary, assessing a patient with a suspected stroke in the ICU involves rapid and systematic evaluation of neurological function, motor and speech abilities, and vital signs, combined with immediate diagnostic imaging and collaborative decision-making to initiate appropriate treatment as quickly as possible.
How would you approach end-of-life care for a patient in the ICU?
Approaching end-of-life care for a patient in the ICU requires a balance of clinical expertise, empathy, and communication to ensure that both the patient's dignity and comfort are prioritized. The first step is acknowledging the gravity of the situation and initiating open, honest discussions with the patient, if possible, and their family about prognosis, treatment options, and goals of care. In many cases, these conversations focus on transitioning from aggressive, curative treatment to palliative care, which focuses on comfort and quality of life. I would begin by ensuring that the patient and their family are fully informed about the patient's condition, prognosis, and any realistic outcomes of continuing life-sustaining treatments. This conversation is best approached with compassion, allowing time for the family to process the information and ask questions. Understanding the patient's values, wishes, and previously expressed preferences, such as through advance directives or discussions with the family, guides the decision-making process. Once the decision to shift towards end-of-life care has been made, the focus would turn to alleviating discomfort and ensuring the patient's comfort during their final days or hours. Pain management becomes a top priority, and I would work closely with the ICU team to administer appropriate medications, such as opioids, to relieve pain or distress. Addressing other symptoms like breathlessness, anxiety, or restlessness is equally important, and medications or interventions would be tailored to the patient's needs. Another key aspect of end-of-life care is creating a peaceful, respectful environment for the patient and their loved ones. In the ICU, this may involve reducing unnecessary interventions, such as frequent monitoring or alarms, and allowing the family to spend as much time as possible with their loved one. If the patient is stable enough, transitioning them to a more private or comfortable setting within the hospital, such as a dedicated palliative care unit, may be considered. I would also provide emotional support to the family during this difficult time. This includes helping them understand what to expect, listening to their concerns, and connecting them with additional resources, such as a chaplain, social worker, or palliative care specialist, if desired. Families often struggle with feelings of guilt, grief, or uncertainty, and my role is to offer them both information and reassurance that everything possible is being done to respect the patient's wishes and ensure a dignified passing. Finally, I would continue to monitor the patient closely for any signs of distress or discomfort and adjust the care plan as needed. Throughout the process, maintaining clear, compassionate communication with both the family and the interdisciplinary team is essential to ensure that everyone involved is aligned with the patient's goals of care. In summary, my approach to end-of-life care in the ICU focuses on clear communication, symptom management, respect for the patient's wishes, and providing emotional support to the family. The ultimate goal is to ensure that the patient's final moments are peaceful, dignified, and free from unnecessary suffering, while helping the family navigate this challenging experience with compassion and understanding.